Fantastic. Thank you so much to everyone for joining. Apologies for the delay in getting started. Just allow me to turn on my camera. Evening, everyone. Thank you so much for joining. Today we have a really exciting lineup. We will be doing this webinar in partnership with APN. So glad to have the APN team with us. I will ask you to just start with a brief introduction of APN and then we can get started. So you can go ahead.
Thank you. Thank you so much, Dr. Jean. My name is Juliet Ouma. I am the Programs Assistant at African Pharmaceutical Network, and it's a pleasure to have each and every one of you join us for this crucial discussion this evening. And I'll quickly take us through the overview of African Pharmaceutical Network, our organization, who we are, and the kind of work that we do. Please confirm that you can see my screen and you can hear me loud and clear.
Yes.
Thank you. So African Pharmaceutical Network was established in 2020 at the backdrop of COVID-19, and it was established as a pan-African network that brings together professionals. These are pharmaceutical professionals, stakeholders, and organizations working within the pharmaceutical industry within Africa for the purpose of knowledge sharing, policy shaping, and innovation nurturing partnerships, leading towards ensuring reliable access to quality, safe, and effective health products and technologies in Africa. So why were we established as an organization? We were established as an organization out of the desire of addressing 3 specific challenges within the industry. And this included limited local manufacturing in Africa, attributed to capacity shortfalls in the continent. Africa as a continent is the 2nd largest continent in the world, following Asia, which is the largest continent with about 4.8 billion people. And as a continent, we also rely on imported products up to 70%. And as an estimate only for the products that we consume as a continent, it is more than $25 billion in a year. But we truly rely on imported products up to 80%. So for us, what then should be the solution for us? With limited local manufacturing and the high disease burdens, we have to come to a place where we are sustainable. Therefore, we have to boost local manufacturing within Africa, that we are able to manufacture from the API to the finished product, so that we can reduce our dependence on other continents, our dependence on other donors as well. The second issue was segregated and disjointed pharmaceutical systems, where we have industry players working within silos, the different industries, the different fields that are within the industries. They are all working in silos, yet they are all working towards a common goal. And this usually makes the work to become more challenging, because more often you might find that the challenge that you are experiencing within your sector is not a challenge that is caused by your own sector, but it's a challenge that is caused by another sector. So therefore, you have to come together. If you're working within the pharmaceutical supply chain system, and maybe your challenge is being caused by regulatory policies, then you have to be able to work with those who are within this field of RA. You guys have to come together, then you are able to work towards a common goal. If we are all established in such kind of a manner where we are able to collaborate, then it is much more easier for us to get to the place where we ensure that we have the products that we need, that our patients and our people are getting the good quality service that they should be getting on a day-to-day basis. The third challenge was the lack of a common platform to convince stakeholders to chart a path for the future of the industry. Now, therefore, APN was established as a pan-African network. If you have interacted with us previously, you've noticed that most of our industry discussion forums, we truly make it, we usually give other stakeholders as well the opportunity to come together as well with us, so that we are able to work together. Today, we are working with KMA. What about tomorrow? Last week, we worked with Ghana FDA. What about tomorrow? We are offering this platform so that every stakeholder within the industry can be able to come together with the others and be able to collaborate. So if you're looking to partner with any one of us, we truly encourage you to reach out to us, and therefore we'll be able to work together. Keep note that in this call, we do not only have pharmacists, we do not only have medical doctors. I know some of us are from the government, some of us are from private sector. So therefore, let us collaborate. So this is our mission as an organization. to ensure reliable access to safe, effective, and quality health products and technologies in Africa through strategic investments in the pharmaceutical workforce development, the business ecosystem services, and policy shaping intervention. And why these three? Because the capacity, the job is as good as the person doing it. And you need to have the right capacity to be able to fulfill your mission in whichever area that you are working in. Therefore, we want to ensure that we have competent professionals, meaningfully engaged professionals within the industry, working towards ensuring reliable access to safe and quality health products. Then we have the business ecosystem support services. This is where we support other organizations in their works as well. If you are in need of LTR services, for example, you're bringing your product into Africa, either one of the countries, and you require support, then we are able to support you with this as well. Even in different research projects, we come on board and just be able to support you. Then we also participate.
To cut you short, I have participants that are saying are not receiving sound. I don't know if it's every participant or it's just a couple of them.
Doc, maybe you can confirm if you can hear me. Lucy, you can confirm if you hear me as well.
Yes, Juliet, I can hear you well. I can't see in the chat who has said, but perhaps if you want to drop off and then join back in again, because you're very.
They are saying they are seeing the KMA logo. I don't know if there were two registration link, and from what have been sent, there seems to be people on that chat saying they can't hear. So I don't know if there are two links or it's only one.
As in, they're not in this Teams meeting; they're in a different meeting.
Yeah, they are saying they're just seeing the KMA logo on the screen, but I'm not sure.
Oh, technology is really trying today. I'm not certain. Where are you chatting with them? Is that on WhatsApp? Because I can't see any comms. They're not in this meeting, right?
Yeah, it's somebody who has forwarded me, one of my colleagues, that they can't hear anything, and they have sent me a chat screenshot of people saying no sound, no picture. What's the matter?
Yeah, so I've gotten this. Sorry, I've gotten the update. Let me follow it up. I think there was another link that was shared with KMA. So let me get these people to join us here.
Perfect. Thank you.
Thanks, Juliet. We'll just give everyone a few minutes to join in, and then we'll kick back up.
All right. Should I pause here?
I think given that there's 90 of us on, we can just continue as the others join us. We'll give if anyone needs to ask any questions, we'll give the opportunity for that.
All right. Thank you. Thank you so much for confirming that. So this is our vision as an organization: reliable access to quality, safe and effective medicines and healthcare technologies in Africa. And also as an organization, we have our values as APN. These are our values: humanity, integrity, professionalism, client value creation, and teamwork. At the core of every work that we do as an organization, humanity is at the core of it. That any product or any service that we are bringing to market, we consider the person who is going to consume this particular product, that it has to be beneficial to them as a person. So we ensure that we have humanity at the core of that which we are doing: integrity, professionalism. When we interact with you, how do we then interact with you? Do you also benefit and gain value from the business and the services that we are offering? And then we have teamwork, where we get to collaborate with the individuals within the organization, but also outside the organization, there has to be teamwork. So this has been our journey since 2020, where we had the inception in 2020. In 2021, we were able to have the industry discussion forums with key industry partners, including FKPM, IFPMA, and Bloom Public Health. Then in 2022, we signed a partnership with Empower School of Health based in Geneva, Switzerland. And as you can see, while we are speaking about collaboration, we are also collaborating with other stakeholders within the industry. Then in 2023, we launched the Pharmacy Academy with our first professional development course, the Regulatory Affairs course. And then in 2024, we were able to scale up by adding 2 more courses. These were the Pharmacovigilance course and the Pharmaceutical Supply Chain Management course. So these are our services: pharmaceutical workforce development under the Pharmacy Academy, regulatory support services, the business ecosystem support, policy shaping, and partnerships. This is our advisory board. And we have Dr. John Paul Omolo, who is our board chairperson. We have Kirtin Nasai, our board member, and Dr. McDonald Olise Yunam as our board member as well. Our management team, we are under the able hands of Dr. Odhiambo David. I know most of us maybe are familiar with him. And then this is the entire team. The management team is at the top. Then we have the secretariat team at the bottom, where we have Dr. Lucy Machocho, our technical programs assistant, myself, and Thomas Ogola. We are also a membership network. If you're looking to join us as well, we have various categories for you. If you're a student in your final year, you can definitely sign up for membership with us. If you're a professional working within the industry, you can also sign up for membership with us. And we also have institutional membership for African institutions based within Africa. We have a slot for you. You are definitely covered. And international institutions as well, you are definitely covered as well in a Pan-African network. So these are our courses under the Pharmacy Academy: the Regulatory Affairs Training, the Pharmaceutical Supply Chain Management Training, and the Pharmacovigilance Training. Please feel free to sign up and to enroll for these courses with us right now. We are currently on our cohort 2 intakes. Please, 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 if you are keen in array, if you're keen in supply chain, if you're keen in pharmacovigilance, we welcome you to enroll and get to train with the best under our Pharmacy Academy. These are our partners up to the point where we are today. We were able to sign up our partnership with ISOP Africa chapter early this year, and we have also been able to secure other partners this year, including PSK and the Pharmaceutical Society of Zimbabwe. The rest have been our partners since 2021 as well. So if you're looking to sign up partnerships, we are open to having collaborations with you as well. Please feel free to reach out to us. You may engage with us in these kinds of ways, where you can become a member, you can partner on projects with us, or you can learn with us. And with that, I have come to the end of my presentation, and I hand it over back to you, Dr. Jean. Thank you.
Thank you so much, Juliet, for taking us through that. That was a fantastic overview. Welcome to those who have joined us. Apologies for the technical issues that you are experiencing. We believe we're set to start. This is a webinar in collaboration with Africa Pharmaceutical Network and Kenya Medical Association. For those who may not be as familiar with KMA, I will give a very brief overview so we can get to our guest speaker for this evening. So KMA is a national professional association, and it brings together medical and dental practitioners in Kenya. It was established in 1968, and KMA has a mandate to uphold ethical medical practice, advise on health policy, support professional development, as well as advocate for universal health access and doctors' interest. There are a number of committees that you can join in KMA. So I'm one of the members of the ICT committee. There's also policy and advocacy, research and ethics, public health, reproductive health, physician well-being, human rights. There's a Young Doctors Network. There's a KMA Trust, as well as the medical journal that is published. And there are regions all across Kenya that you can join. If you are not a member of KMA, please do link up with us, ask us how you can join so that we can provide that information for you. This is one of the ways in which we engage members, by providing them with access to information, by doing these webinars, and this is a CPD accredited one. So my name is Dr. Jean Kula. I will be your moderator for today. I'm very excited to introduce you to our guest speaker for today. We know the USG, the United States government stop order that came abruptly in January, disrupted the way in which we do service delivery, and it threatened the very existence of our data health systems. Now we know some of the systems that were affected: AFIA-KE, DHIS2, Chanjo, and many others. And Peter will be taking us through what that actually means for us in practice. So by way of introduction, Peter Macharia is a spatial epidemiologist, and he's based at the Institute of Tropical Medicine in Belgium, and he's a visiting scientist at Kemri Wellcome Trust Research Program here in Nairobi. So his work in spatial health metrics focuses on improving the understanding of health disparities and inequalities at high spatial and temporary resolution in sub-Saharan Africa. particularly the geographic access to healthcare population marginalization and vulnerability, coverage of interventions, disease prevalence, and associated determinants. He has vast experience using household data surveillance and from the DHS program and routing data from DHIS2 for the last 10 years. Peter holds a PhD in spatial epidemiology, a master's degree in GIS and remote sensing, and a postgraduate diploma in health research, and a BSc in geomatics engineering and GIS. So you will agree with me, Peter is more than qualified to take us through this conversation, and we're really looking forward over the next 40 plus minutes just to hear from him, hear his insights. And if you have any questions, as always, to put them into the chat. We will go through the presentation first, and then we'll have a Q&A session. So Peter, over to you. Karibu sana.
Thank you very much. I'm going to put up my slide. Let me know if you can see my slides in presentation mode.
Yes, we can, Peter. Please do go ahead.
Perfect. Thank you. So I want to begin from the beginning, before I begin. And I want to start with why this convergence matters and why we have to be here and why we have to talk about this. So I was just going through different media outlets and things that they have said linked to the data sets that we are going to be talking about today. Particularly, we are going to be talking about the DHS program data, one of the data sets that was affected by the USAID halting. So there are many things that were stopped, but particularly today, we are going to talk about the DHS program data sets. And if you go to one of the Daily Nation pages, this is what I found. A third of Kenyan men mistreated by partners. And this is the link from which I snipped this. And below it, they mentioned that the 2022 KDHS indicates that 6% of men have experienced economic, psychological, or emotional, or physical, or sexual violence at some point in their relationship. The only thing that I want you to mark here is the 2022 KDHS dataset. So they said all this based on this article. They talked about the 2022 KHS dataset. So if we go to a different news outlet, so here, this is, again, Nation Media Group, and this is October 2023. It was 16 million boost for maternal and child health. And this was the Kenya National Demographic and Health Survey 2022 reports that 11% of girls aged 15 to 19 years in Kisumu have experienced pregnancy. Again, just marking here that they used 2022 KDHS data as a foundation to what they were writing about this piece. I didn't read more about it, but you can see it's about maternal health and child health in Kisumu. And they are saying that 11% of the adolescents have ever gotten pregnant in Kisumu County. Then again, from Nation Media Group, we have why Kenya is likely to face a HIV crisis. So this is like a news article to lobby about something and to communicate about something. And here is why we should plan maybe better about a looming HIV crisis. And below there, the writer of this article says, nearly half of Kenyan teenagers aged 15 to 17 years do not know how to protect themselves from HIV/AIDS infection based on Kenya Demographic and Health Survey 2022. So they are using this data set as a foundation to what they want to talk about or make the public know about or the government know about. Another one from the Star, Bungoma police flag domestic violence cases. Again, they cite 2022 Kenya Demographic and Health Survey, saying that a high percentage of women aged between 15 and 49 have ever experienced physical violence since age 15. And they are saying the sexual violence is highest in Bungoma, 62%. And this, again, is from the 2022 Kenya Demographic and Health Survey. We go to Nyandarua County. Again, they cite something about nutrition, and it's founded on KDHS 2022 dataset. So if they are using all this to lobby about different things, founded on data that was collected in Kenya around 2022, 2021, and made public to people. So I think this gives us an idea why we need to invest on data, and not only data, but quality data. So you can see this meme, what these two people are saying. So you don't want to invest in data quality, but you want to be data driven. So basically we can't do anything if we don't have quality data. And here is DHS program data, and I've just given examples of KDHS 2022, how they have been cited recently within the Kenyan media. This is something that I generated earlier today using AI. And if we don't have data, definitely we will be flying blind. So you can see this is an aeroplane that is just about to crash in photo 1, and in second photo is just about to crash. So with no data, we are flying behind. Then let's now go to what has just happened. So we have USAID, which freezed and halted some programs. And among those programs is the DHS program. And all the things that I've mentioned before, they were based on DHS program data. Now, what does this mean if we don't have funding to continue doing surveys that were based on the DHS program going on? So this is what I want to try to talk about. And my outline is, I want to talk about who I am in regard to this talk, and why I'm giving this talk. So about positionality statement, then talk a little bit about what this program is that was terminated. Then what is the implication of the termination of this program going forward, given that we've been relying on this data set a lot. And there are so many things that surround the way the DHS program was providing this data to us that now is at jeopardy, that going ahead, we might not be able to access a lot of good things. What should we do? What does it mean for these data systems? So a little bit about myself. So I remember in 2021, 2022, the DHS program was talking to DHS data users about how they have been using the DHS data sets. And I was one of the people who were featured about using the DHS data for quite some time. And I remember without DHS data, we will be flying blind. That's a quote that I just used when I was talking about how I've used DHS data in the context of Kenya and Sub-Saharan Africa. I really never knew that this was ever going to happen, that we no longer have DHS data going forward or going to do more DHS surveys, maybe, I don't know. And this means it's just like you are flying and you don't have somebody handling that plane, and we are just likely going to crash, but we are going to see more of that as we go on. So I've used DHS data since 2015. So I'm talking from that position of a user who have used this data set for over a decade. And I use it from a geospatial angle, and DHS collects data that has allocation in it. So I attribute everything that I do with DHS data to allocation. And it's good to say I'm Kenyan, so I know a bit about Kenya and how we use our data sets. And I have used a lot of these DHS datasets when I was based at Kemri Wellcome Trust, that is 2015, 2020. I'm still a visiting researcher in the program, but at the moment, I'm a senior postdoc at Institute of Tropical Medicine here in Belgium. So largely what I'm going to talk about today is based on my experiences of using these datasets and what I think might happen with the stopping of the USAID program and the DHS program. So if I start from the very beginning, and we think what the DHS program is, some of us might know, some of us might not. So this is a program that was established in 1984, and it was established with funding from USAID. And before its establishment, we had a program that was running before, which was the World Fertility Surveys, that had been running over a decade. So this came to replace that program. And this program, the DHS program, is specifically called, it's a global initiative, basically for a lot of low, middle income countries, where they collect data, analyze that data, and then they disseminate it And it's usually nationally representative. So we can say something about Kenya, we can say something about Uganda using that data as a whole, but we can also say about some subnational elements for some countries. That's why we would say something about Nyandarua County, Kisumu County, based on this data set. And again, it is open source. So you don't have to pay to use this data set. So it's owned by the country, but also somebody in Rwanda can use data set for Kenya or for Mali, for another country. So it's open source for anybody who wants to use it for research purposes, to make some public health good out of it. So a snapshot here of the surveys that have been carried by this program over the years since 1984. They have done over 400 surveys in more than 90 countries. The darker the color for the map that I'm showing here, the more the surveys that have been done for that country. If you look at Kenya, we are among the darker color. So it means from the DHS program, a lot of surveys have been conducted. And we shall see later, these are 13, almost 14 surveys, not yet 14. And we will talk about the not almost 14 surveys, why. If you look over time about the surveys that have been done, from the time they updated this, the DHS program, I think this was January this year, it was 452 surveys in 92 countries, and they had 25 surveys ongoing by then. The blue colors here over time are showing surveys that have been done in Sub-Saharan Africa. Then you have other surveys that are done in South and Southeast Asia, North Africa and West Asia, Latin America and Central Asia. But you can see majority of those surveys are happening in Sub-Saharan Africa. This is the blue color. From 1984 all the way to 2025, you can see quite high number of surveys have been done. And what does this DHS program provide? So they do 3 types of surveys, or they have been doing 3 types of surveys. So you have the demographic and health survey, the one that was cited by all those news outlets that I showed earlier. Then you have a malaria indicator survey. So these 2 are community surveys that they go to households. A lot of the time they talk to women about a lot of things linked to our demographics and health, and also more about diseases like malaria, for example, anemia. So we know a lot about our demographic and health from these surveys that have been carried from 3 to 5 years. And we shall see how many surveys have been done in Kenya and in what years. So normally these surveys are country owned. So this is a survey for Kenya, and it's usually led by national statistical offices. And in the case of Kenya, it would be KNBS partnering with many other people to do this survey. And the DHS program provides technical assistance to make this happen. So there is a bit of funding and a lot of technical assistance provided to process the data, to run the survey, and the usage of these data and capacity building. So the DHS has been doing a lot of things so that we can make use of these data sets in the best way possible. So, and the DHS program goes ahead to make the data publicly available to anybody who might want to use it. But of course, you have to register in a certain portal and say why you want to access the data. Then they will allow you to access the data after you review. A lot of topics are covered by the DHS program. So you have things to do with the child mortality, you have family planning, you have gender-related issues, malaria, maternal mortality, nutrition, household wealth index, a lot to do with sustainable development goals. So it's a package of so many things that the DHS program has been doing within these 3 key surveys that have been happening in countries, including Kenya. So these are the surveys that have been done in Kenya since 1989. So that's when, so after 1984, the first survey came into Kenya in 1989. So when they started with a standard DHS, so you can see they have done a number of DHS over time. They have done the service provision assessment surveys over time, and they have also done malaria indicator surveys over time. So we are a bit lucky. The last DHS to be done in Kenya was in 2022, and the data sets are already available out there. The reports are already out. Kenya Malaria Indicator Survey 2025 has not yet happened, and that's one of the things we will be at risk of. And how normally would you access such data set? So you have Kenya National Data Archive. This is hosted by KNBS. And you can access all these data sets that have been conducted in Kenya from this platform. You can also access this data set from the DHS program website. And also you can access it from the IPAMS DHS website. There are a lot of advantages that comes with accessing these data sets from the DHS program, and I think that might be the core of the talk. You can access it from the KNBS website, but the DHS program will offer you a lot of support through some many data systems that they are using that you are not going to get with KNBS. So we can continue to access the Kenyan data from Kenya National Data Archive, but we are going to lose so many things in between there for which the DHS program was offering, which if the systems are not going to go ahead, it means we are going to lose a lot, and we are going to see more about it. So I just wondered, or you might be wondering then, how have we used these data sets from the DHS program? So I just skimmed a little bit. I know we've used it a lot, but I just want to point out just a few areas. So you have the Kenya Malaria Strategy 2023-2027. If you just go, I think the Kenya Malaria Indicator Survey is mentioned in this report over almost 30 times, but I just picked one of them. And here they are saying about the epidemiology of malaria in Kenya, and they say the Kenya Malaria Indicator Survey 2020, then they based the rest of this based on what they found on the survey that was done in 2020, the KMIS 2020. So imagine a situation where this did not exist, where we had not been able to carry this survey, or we didn't have the capacity to analyze the data sets from this survey. Then another random thing that I looked at is the Kenya COVID-19 recovery, supporting access to finance and enterprise recovery. This was a gender-based violence action plan. They cite the 2014 Kenya Demographic and Health Survey, which says that 1 in 4 women reported physical or sexual violence from a partner in the 12 months before the survey. So these key government documents are looking back at the data sets that we've collected with KNBS, but with a lot of support from the DHS program. If you go to things that are lobbying about things that we should be doing better, so this is Institute of Economic Affairs, they say, reducing child mortality in Kenya is both urgent and possible. And they are basing these from the KDH 2022. Then another article by The Nation, they say, Kenya off track towards achieving 2030 child mortality target. This was July 28, 2024. That's when this article was written. And again, it is borrowing from KDHS data or data that has been collected by the DHS program. This is something that we did with colleagues. This was part of my PhD back then. And we worked with people from Ministry of Health and specifically the Department of Malaria Control. And here we were looking at how malaria prevalence had changed in Kenya over the years. This is 1990 and this is 2015. So just to inform, where do we need to do more? You can see in the coastal Kenya and Western Kenya, we need to a little bit do more. So we need to introduce other things. And for example, we know the malaria vaccine has been introduced in Western Kenya, rightly so, that's the right area to introduce. And there might also be other areas that we don't need to use a lot of effort. We need to change maybe, for example, and go to surveillance or other things. So these data sets that we used here were partly collected within DHS data, MIS data, and combined using geospatial methods to see how we've done over time. So we can track our progress over time based on these data sets that have been collected with people from Kenya and technical support offered by the DHS program with other partners. Another example, this is also work that I had done back then. This is child mortality in Kenya, how it had changed from 1965 to 2013. So you can see from 1965, we have a lot of reds. So saying under 5 mortality per 1,000 live births, very high. But by 2013, you can see how the map looked like. But that's not my main message here. My main message is this map was possible because we had access to data sets and we had resources that we could use to make this happen, to be able to know how child survival has been since independence in Kenya. Just looking overall about people who have been using DHS data in Kenya, based on the DHS website, they are saying we've done 14 surveys. So these are 13. The last one is not yet complete. About 200,000 people have had website sessions looking at the Kenya data. They have trained over 3,000 people to look at these data sets. They have a program called Start Compiler, which you can go easily and look for a lot of statistics about Kenya, nationally, over time, subnationally, a lot of this. Over 20,000 sessions on this program that is readily available to anybody to look at all these data sets that have been collected in Kenya over time. We have had almost 400,000 data sets download related to Kenya, so just to analyze data sets about Kenya and whatever is happening in Kenya. Then they have another mobile app that you can still access a few things about DHS. So you've had about 2,000 downloads. So you can see this data is being used and hopefully being used for good. Then the question is now, what is the status of this program? So on 27th of January, there was a stop work order to terminate the work that was going under the DHS program, irrespective of where the country was at. Whether you are collecting data, whether you're analyzing data, or whatever you are doing, stop it there. So the public website of the DHS program, as per now, is still live. If you type it, you'll still be able to access it. But they're not adding any more data sets. No new requests are being approved. So for example, if today you want to access your data as a researcher or a policymaker or a medic, you are not going to be able to access if you didn't have a program or an account with them before this. And the DHS program, however, has been able to share some of the data sets that it was almost finalizing for some countries where some surveys were ongoing and they were the final stages of cleaning the data. So these, I think, has been shared with the countries. So if you go to the DHS program, you'll find this message. Due to the ongoing review of US Foreign Assistance Program, the DHS program is currently on pause. We are unable to respond to any data or any other request this time. We ask for your patience. If you go to another website that also offers DHS data that I mentioned, IPAMS DHS, so they say registration and access for IPAMS DHS is managed by the DHS program, which is not reviewing new user application or request for expanded access from currently approved users at this time. But if you had registered with the IPAMS before, you are going to be able to access the data. But if you hadn't, you will not be able to be registered as a new user. So when this happened all around the world, people said things. So one said, pausing progress, the uncertain future of the DHS program. Then the New York Times said, Trump administration ends global health research program. The demographic and health survey were the only sources of reliable information in many countries on metrics such as mortality, nutrition, and education. The International Union for Scientific Study of Population said, the end of the DHS program, a major issue for research and sustainable development. Another group said, critical global surveys fall casualty to US foreign and aid gutting. These will impact the global community ability to track progress around the United Nations Sustainable Development Goals. The end of an era, USAID termination of the DHS program and its impact on the data community. Then an article from Kenya, how US funding freeze derails tracking of the disease outbreaks. Where we came in as a group of many researchers, we wrote a debate article because we thought this is not the time to keep silent if this has happened. And we've been using these data sets for many years. We know what it is capable of. We know what it has been doing. So a group of 30 researchers here who are health workers, national policymakers, students, educators, and researchers who have relied on the data, methods, and findings produced by the DHS program and use this data for decision making. So we wrote an article around the importance of the DHS program and how the future might look like if this program is no longer going to exist. So when health data go dark, or when we are flying blind. some of the key things that we mentioned here, what are going to be the impacts on the ongoing data collection and processing, lack of population health indicators going forward, and access to existing data and lack of support for its use. So these are likely some of the key impacts that I want to dig a little deeper into. And I will start with the disruptions to the ongoing activities. You might think we are not affected, but we are as Kenyans. So the Kenya MIS 2025, which was scheduled to be done in June 2025 to September 2025, I don't know its future. It would have easily been conducted, finished. We take progress of how we are doing in terms of malaria prevalence across Kenya, how the malaria vaccine is doing, whether we need to introduce bed in some areas, whether we need to continue indoor residual spraying, whether our drugs that we recommend, like ACTs, how they are working. So there was a lot at stake, but right now I'm not sure whether that survey is going to be done or not. I'm not the best one placed to speak, but you can see many countries have been affected. That was a stream of data that has been collected for over many years, and it has helped us to track so many things, even advocate for funding, and know where to do what at what time. Whether this is going to happen or not, we will wait and see. We might have suggestions of how we can better use the existing resources to still carry a malaria indicator survey, but that is not the talk for today. So we have so many indicators that can be monitored at the population level for a lot of evidence. You can see a lot of documents for the government in Kenya, health-wise and demographic, are relying on data from the DHS or MIS or SPA. Now, if this is no longer going to go ahead, what happens? We use this data a lot to make people accountable, to make government accountable, to make a lot of decisions. And what if this data is no longer going to be available by the stopping of this program? So you can see what is at stake. This data has been collected since 1973 when we had WFS program. Now it's the DHS program, but this is under threat because how will we continue having such data sets over time if this is going to be stopped? Then there is the USAID funding has stopped. How will we monitor the effect of its stoppage? We would have needed data to say, okay, after the funding was stopped, this and this and this happened. But we don't have data sets that will be collected further, maybe, to be able to track the same thing. So it's a bit ironical. So the data that would have helped us monitor such a phenomena is not going to be any longer available to us. But I think even more worrying is we go to the villages, we go to our parents, our uncles, our friends, and especially women, and we sit them down, we ask them a lot of questions, promising them that these data sets will be used for greater good of the community and of the Kenya. And again, now we go back and say, we are going to stop this program. So it brings a lot of ethical issues around that point, because we promised them A and then we are delivering B. If we go back again to them, are they going to trust us? Or would they think these are just people playing around with our minds? And from where I stand, it is not just about accessing these data sets. The DHS program has been offering a lot of technical support tools and documentation, which I will list here, that might get lost. Then over time, we are able to compare and track progress for SDGs between countries, across countries. But now, if I can't access data for Uganda, Rwanda, Tanzania, this likely is not going to be possible. For example, here you can see some work we did in East Africa. This was malaria prevalence, borrowing from data from DHS program and other data sets, and we were able to see how Kenya is doing, or Tanzania relative to Uganda and the rest. Whether this is going to be possible going forward, that's another question, because are we going to have another program that is going to continually collect such data sets? Another piece of work that we had done here, we looked at after a child has fever, how many go to the hospital per 1,000 children. So this is treatment seeking for fever. And you can see this is across sub-Saharan Africa. This was led by one of my colleagues back then. So we can compare between countries because we have access to this data. This data is standardized, it's in the same format. So one can be able to do such an analysis. And you can see, for example, DRC, seeing Ethiopia, partly Somalia, Central African Republic, you can see how they are doing. Maybe Angola is doing better, Namibia slightly better. So we are able to compare between countries and know what is going on. But now without access to these data sets and the digital platform that they offered us, are we going to be able to do this? Very important is a lot of people have been trained around these data sets to be experts of data analysis, data scientists, by using these data sets. So we had courses on survey methodologies, a lot of masters, undergraduate, PhD students in low-medium income countries, including Kenya, and I'm a product of being trained using DHS dataset. It's likely going to go away if we can't access these datasets anymore, or the program is not going to continue. Then we need future leaders. We saw COVID-19, we saw Ebola, we saw Mpox. Do we know what is next, and are we ready for it if we are not being prepared to deal with this? This is a good example. Here at the Institute of Tropical Medicine, we ran a course, write your paper based on DHS data on sexual and reproductive health. This course is going on this week, actually, and the application for the next year is open. But are we going to be able to continue to do this course if these datasets will not be accessible? So here we are training people from different low middle income countries to look at these datasets and make decisions and policies for their countries. But is this going to be possible anymore? I was looking at what DHS program has trained for Kenyans, and you can see from 1990 all the way to 2025, they've been training quite a good number of Kenyans. In Kenya, I think it was around 3,000, and you can see we have women and men both being trained. Here, I look at the DHS program in 2014. We had 2 Kenyans from Maseno University, I think, who were trained. So it's an ongoing training that they do. So the program now is not there because the DHS program is no longer there because there is no funding. Then it's not only that form of training. They do a lot of in-country activities. They do regional and national training. Whatever I showed you earlier was the DHS Fellow program, where a group of people go and they are trained in depth how to analyze these data sets. There is a lot of online training. They have south-to-south consultants, workshop, and many things that they have been training people on, basically building capacity. But this is now at stake because the program is not there anymore, not unless something different happens. I think we wanted more about data system and things. From YouTube, they have a lot of training that they have been doing, but more importantly is the GitHub page for the DHS program. Everything that they have done and produced, they put the R code, the SSP code, and the stata codes available to everyone to use, manipulate, play around like the way they want. This might no longer be maintained further if we don't have funding to sustain it. So easily somebody can come here and edit a code or modify a code to get new insight instead of rediscovering the wheel, but that is still at stake. Also, you have the DHS Program User Forum. Here, people ask all sorts of questions, clarifications. So it's a learning platform also that now there is nobody on the other side of the DHS program saying, this is what you should do if you have such and such a question. Key technical assistance they have been providing us that is likely to get lost. The way we do our sampling, The sampling strategy is all supported by the DHS program. How we do the biomarkers for the different diseases. A lot of data processing is also supported by the DHS program. They have a lot of things that we can't go through today that the program has been providing. So this is a snapshot of many of the digital tools that they have been offering for us to use. I've talked about the DHS user forum, the GitHub page. They have a lot of these. And for example, if today you wanted to know access to electricity in Kenya, it took me less than 2 minutes to generate this from one of their tools. So I can see how access to electricity in Kenya looks like. I can see it's higher in central Kenya, a bit of western Kenya, but in northern Kenya, access to electricity is poor. If you look at unmet need for family planning, you can see northern Kenya and a bit of east Kenya is also affected. It took me less than 2 minutes to put this here, but it is likely no longer to be there, but it was a program available online for anybody to go access and get the statistics they want. Assume this was somebody in the planning department for Kenya linked to family planning, and they can easily use these and want to know what is happening, for example, in northern counties, for example, here in West Pokot, what is going on. Around spatial data, I deal with spatial data. They have a lot of digital resources that they had provided us with. And I'm just going to highlight one of these, but there are many of them, which if we want to look at each, we will need some time to look at each keenly. So you can see, for example, access to bednets in Kenya at high resolution. So you can see where access is low and where access is high if you wanted to go to the exact village. So they were adding value to the data sets that they were providing, and this is available for anyone to access. Then you have people who are using open defecation. So this is a big concern, but you can see where we have a lot of reds where this issue might be if you just wanted to go and target there. So this is something that they were providing using through one of their digital platforms that they had. People are trying. There is a group that has tried to archive the data set. So this is, they have put all the DHS indicators here, something that anybody can access. All the publications have been put here, and they are saying they will add functionality soon. So this was 25th February 2025. This is when they did this. When we wrote that article, we were thinking, what then does it mean, or what might we do? And we were asking whether, or we think they should restore all the data that was existing and all those platforms and documentation that I've mentioned, such that people can continually access this. In the short term, we hope like MIS Kenya will be done, will be completed. All those surveys that were planned, all ongoing, at least to be completed. But there is a big question for us as Kenyans and other people. So in the long term, should we change how we do these surveys and how we fund them? The good thing about the DHS is the data was comparable, open access, there is technical expertise, there was standardization of methods, sampling techniques, data coding. So can we have such an alternative that will continually do something similar to what DHS was doing if DHS will never come back? And one of the things, for example, can we have a server that is centralized, say within low middle income country? So we have something in Kenya, something in Rwanda, something in Mali, such that we are never going to be affected by this again. It's also protected from all the political and funding things that might happen. So is that something that we can do? Is that something that we can think? So because this has happened, do we want to avoid it never happening again? What should we do? And more important, this has been a very big debate around. So should we think differently about external funding? Should we now start telling our government, you need to put enough money on ABCD because it is important for us on ABCD, or we are going to talk more about politics and less of this? Then strengthen our technical capacity in Kenya such that, okay, the DHS program is not there, but we have Kenyans who can do everything that was being done, but supported by funding from the Kenyan government, so that we are self-reliant on ourselves. So we really reduce the financial dependence that we have, that we were relying from the DHS and other things. Then I'm almost concluding, but somebody is asking, we have DHIS2. Why are you not talking about DHIS2? Why not DHIS? Why not use it? But I know most of you saw this. The DHIS2 in Kenya, based on the sources that I've cited here, was also affected by the funding. The servers were off momentarily. I don't know if the KHIS2 is already back or not, but according to this source, it is suggested that it was down. People could not download data because it also relied from some funding from USAID for the server to run based on this source. Beyond that, the data from KHIS in Kenya, we know it has a lot of missingness issues. A lot of facilities are not reporting. Those that report, sometimes the data is not good. I've used that data. I'm talking from a user perspective, so I know how it looks like. And I've seen that data for other low middle income countries too. So do we use this data set? But even if we were to use this data set, and it was also relying on external funding for the servers to run. Okay, let's say it was not relying on external funding. How are we ready to solve all the issues that comes with routine data to be able to use it properly? Will this data tell us all the things that the DHS program was telling us, even in a better way? Do we have capacity to analyze these data sets? Can we convince people recording these data sets at the facility to improve what they are doing so that we can use this data to make meaningful decisions? So those are all questions that come up, but that is where we are left with this funding. So I think it's time that we think how we need to reimagine this whole system so that the Kenyan data set system and low middle income country in general continually become available, and we continually build capacity and keep doing things even better than we were doing them. And my last slide would be, so anything that you say without data, it's opinion. It needs to be supported by data. So we need really better data systems. And now with what has happened, I think we need to sit down and think deeply what our next actions will be, or in 5 years' time, we do not have any data system that can tell us something in enough confidence that this is what has been happening into Kenya in terms of demographics, health, all those things that you might want to imagine. I think that's what I'm able to say within 40 minutes, and I will hand it back over to the moderator.
Thank you so much, Dr. Peter. That was a really informative session. You've taken us through the journey of DHS from its inception and from everything that we've been able to accomplish. Thank you for that deep dive. And I can see that there's some comments in the chat, so we'll move straight through to the Q&A. So the first one is from Dr. Lulu, and she said, thank you. You've done a great job elucidating what USG has done from inception to date. And she applauds their efforts. So she has two questions here. The first one being, why can't we access that data and domicile it and now rethink financing of data management at the Ministry of Health? So really in terms of sustainability of the data health systems. There's a second part to it, asking whether anyone at MOH has made a case to Treasury as to the importance of this data. You know, even as you started, showing us, all the references to DHS data. Has anyone even just showcased that to Treasury? And why is local data stored and controlled outside of the MOH jurisdiction? Even with the Data Protection Act, we know all these regulations that exist. Why are we allowing our sensitive health data to be stored outside? And who does that data belong to? I suggest you reach out to key people and develop strategy that works. So maybe you can start with the first question, and then the second one is more for anyone to comment on. Thanks, Dr. Peter.
Thanks for that. So one thing that I would like to clarify is that the DHS data or data from the DHS program is also available on the KNBS website. So if you go to KNBS website, you are able to access that data set. The DHS program then houses data from all the low middle income countries on one platform. So data from Kenya is also housed on the external platform by the DHS. These are agreements that have been done by countries. So they're not doing a wrong thing in hosting it. It's something that has been agreed upon. But I think the key thing is the add-ons that come to the DHS program that are not going to be lost, given that if you go to the KNBS website, you are just going to be able to download just the data set, but the support around how to analyze it, look at it, compare with other countries in a standard way that is standardized is what is going to get lost if this program does not continue collecting such data sets. Just to comment on the second part, I think the second part was might be linked more to the DHIS2 data rather than to the DHS program data about the server going down based on where it was and the US funding went down. But the source that put that information, there wasn't a lot of details to look at it, but I think there are more other qualified people who might speak about DHIS2 data set and the servers and where they are and the storage around that.
Thank you so much, Dr. Peter, for that. Do we have anyone else with any questions? Dr. Peter, just to ask you, in the immediate next steps, what do you see as being the critical things that we need to put in place so that we can continue to ensure that we are not unprepared for a global emergency that could occur, or even just for like the malaria indicator survey that was due to start from next month? What are some of the things that we can practically start doing so that we can make progress towards our goals?
So I think the very practical thing, which is very hard, is if the government started by seeing the value, so they have funding that is not external but is local. Because if we had local funding plus local technical capacity, then at Kenya level, things would be okay for us. Because if the MIS was depending on 100% on Kenya funding, then the MIS would happen. And if we have the technical capacity to analyze it, then this would be okay for us. I don't know if we are going to reach a convergence of those two things where we have local funding plus local expertise where we don't depend on anything externally to be able to look at the data set. Then the other thing is around how we store data and allow other people to access the data within the Kenyan context to be able to analyze it and make more insights from it. So like we are more self-reliant at a local level.
Fantastic. Thanks for that. And as we're talking about the local capacity, the local expertise, the 3,000 that were trained that you referenced, are there ways in which we can have like knowledge sharing taking place, like knowledge exchange? Are there, things that you've seen from practice that we can perhaps, whether it's even informally in the meantime, as we all figure out this stop order, this funding crisis, are there things that we can tangibly do to build that local capacity and ensure that we don't lose that technical expertise?
I think there is something that we can do. I saw recently there was a global meeting about the DHS and the stop of the funding. So people from many organizations globally met. So I think we can have an equivalent in Kenya. I know there are many stakeholders within the DHS who use DHS program datasets, who have technical capacity about it, from collecting datasets out there in the community, analyzing it, archiving it, publication, making policy and decision of it. I think there are many people within the Kenya spectrum that can actually come together and think what is our next step. So I think we have a starting point, but I don't know who is the person who is going to rally the Kenyans together, who are in this space, and we think how we can reimagine the future for ourselves. So I think that might be a better starting point for us. Come together, think what is our next step. I think we have many people who have worked with the DHS program datasets. They have different levels of expertise. So if only we came together, I think we might have solutions to ourselves as Kenyans.
And with regards to like the vulnerabilities, do you see any particular challenges, with the lack of maintenance that is happening? Are there threats that could happen? Obviously, cybersecurity, all these things that are topical. What are some of the things that we need to be wary of in the midst of all of this?
So I think one of the key things around that is data privacy and confidentiality, especially around the DHS dataset. Whatever the DHS program has been doing is to make sure that the data cannot be identified back to wherever it was collected, so that they protect whoever responded to that. So they have been doing a good job of it. For example, the location that comes with the data is always geoscrambled with 5 kilometers, 2 kilometers, 10 kilometers. So we cannot identify back. But I also think our IT sector also needs to do the necessary to make sure we don't have like external access to people who are not supposed to be accessing the data sets. In the case of the DHS data or even the KNBS website, there are levels or layers that have been put in place to allow the rightful people to access the data. But I think it can be tightened because in many countries we are seeing what can happen if wrong people get access to these data sets. But I think around the DHS data is more around confidentiality and privacy of the people who actually answer to these questions, making sure that is protected as it should be. So maybe it's the key thing to make sure when we take over this.
Matt, that leads to the next question I have. You've talked about confidentiality and privacy. Obviously, when people heard all about this, there was now a certain level of distrust of the system. So are we worried that, even if things do get back up, we manage to find like local funding and we become self-sufficient, people might not be as willing to give their data because of these vulnerabilities that were exposed?
I agree with you, and I can also leave for others to pitch in there. But for example, given that we went to the community, asked questions, we got responses, and now we are telling these people this data set cannot be accessed anymore. So that's one ethical issue that comes up. So I think there are so many things to be debated about, but I can't say that I'm the expert to talk about all of this. But I think if we come together, as I stated earlier, people with different expertise and each one puts their comments on the ground, I think we can do something. We can start somewhere. And I'm also seeing on the chat that somebody is still following up on the question on ownership of the MOH essential data set. So going back to that question, I think the data set on the DHS and being on the DHS program and being on the KNBS website, it was designed to be so. There are agreements that have been signed, but about the DHIS2 data, that's a different story. That is a data set that is owned by MOH. The access is controlled by MOH. So you can't access that data set if you don't have like some credentials to access that data given by the unit that manages it within the MOH. But the DHS data, as long as you have credentials from the DHS program, they see what you want to do the data sets with, they allow you access to it. That's as far as I know between the two data sets and access to it and safeguarding the access of the routine data and the survey data.
Thank you so much, Dr. Peter. Dr. Lulu, please do let us know if that has answered your question. I'm not seeing any others popping up. So, Dr. Peter, I'll just let you give your closing remarks as we come to the end of the webinar.
I think my last word would be this is the time to come together and try to reimagine a different future for us without external funding, a time for us to reflect on what we can do with what we have and convince our government why this is important. I think we are in such a time that we need to do that at this time. If we don't do this now, in the coming 5 to 10 years, people will be talking about lack of data, and the decisions that we are going to make obviously are not going to be based on good or robust data sets. So I think it's time as Kenyans and people in global health and low middle income countries came together and reimagined a different future that has no external funding for the collection of these survey data sets. So I think that's my voice, especially to ask Kenyans at this moment. Thank you.
Thank you. Thank you so much, Dr. Peter. Juliet, any last remarks from you?
For me, it's to say thank you so much, Doc, for taking us through this session this evening. It's definitely something that we should definitely look into as we continue to ensure that we are coming to a place where we are self-sustainable as an organization and even as a country and even as a continent. So when it comes to data, it's very critical. We need to have it, and so that we can be able to make informed decisions. So thank you so much, Doc, for taking us through that. And I hope that our audience have found this session to be valuable to them and their work. Back to you, Dr. Jane.
Thank you, Juliet. Indeed, out of this crisis is an opportunity for us to cause that catalytic change. And like you said, we do all need to come together. A phrase I like to use is a coalition of the willing. So it's not just one person who come up with a solution. How can we ensure that we have these sustainable and domestically financed systems? Because we are the ones who will be affected. The populations that we serve are the ones that will be affected. So in coming together and brainstorming and thinking through, it's really exposed how over-reliant we were. And so there's a real opportunity for us to be the change that we want to see. Thank you to all of you who joined this evening. The recording will be made available. Dr. Peter, I'm not sure if you're able to share your slides, but for those who'd like that, we can follow up and see if that's a possibility. Thank you again for all the insights that you shared. It's been a really interesting session. You've really been able to take us through the journey and given us a lot to think through. So thanks to everyone who's joined. Do have yourselves a lovely Tuesday evening. We've come to the end.